मैं डॉक्टर पारिक सर से बात कर लूंगा, जहां वो कहेंगे वहीं कर देंगे सर।
जी सर।
ठीक ठीक।
शुरू करें सर।
या
हाँ जी।
हाँ सर, मृत्युंजय सर, प्रेसिडेंट सर ने शुरू करने को कहा है, शुरू कर दिया जाए।
एकदम।
हाँ, तुम ही शुरू करो ना।
नहीं, आपने लिखा था एग्जैक्टली 8 o'clock।
ये सर, एग्जैक्टली
अभिषेक।
एट 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 थ्री में था सर, 8:03 इट इज।
शुरू करो, शुरू करो।
5 मिनट 5 मिनट सोशलाइजेशन के लिए था सर।
आपका
हाँ हाँ।
एक्टिवेट।
मृत्युंजय सर
हाँ
प्लीज स्टार्ट।
हाँ कर।
अनम्यूट अनम्यूट योरसेल्फ। मृत्युंजय,
हाँ.
अनम्यूट।
So I welcome you all for this webinar, and I hope both the speaker will do well with their topic. And for the session, to start the session, I request Dr. Abhishek to kindly start with Ganesh. We do start with Saraswati Bandhan. So I will request
नो
Abhishek to
सर,
start with Saraswati Bandhan.
फर्स्ट ऑफ ऑल, I will like to request the scientific chairman, Professor K.K. Lohani sir, for the welcome address.
Thank you, Abhishek. Good evening, everybody. Am I audible?
Yes, yes.
Yes.
On behalf of Clinical Cardiodiabetic Society of India, I welcome you all in our monthly E-Cme program. I especially welcome our founder president, Dr. A.N. Rai, President Dr. K.K. Parikh, Dean Dr. A.K. Virmani, all speakers and chairpersons. As mentioned in the schedule, the speakers and chairpersons will be properly introduced by our moderator. In the meantime, let me tell you that today we are going to discuss two very important topics, important from clinical point of view: diabetes with dyslipidemia, current guidelines, especially Indian guidelines, and diabetes with hypertension in Indian perspective. I'm thankful to both speakers, Dr. S.S. Daria and Dr. L. Srinivas Murthy, for accepting my request to discuss this topic for all of us on the very first request. So special thanks from my side as a chairman to Dr. Daria and Dr. L. Srinivas Murthy. And with these few words, I hand over the mic to the master of ceremony. Thank you.
Sir, you are mute. Mrityunjay sir, you are mute.
Now I will request Dr. Parikh sir, our president, Ccdsi, to say a few words and encourage our speakers and the delegates.
Thank you, Dr. Mrityunjay Singh. Uh, it's really an opportunity and an honor to welcome all of you on this E-Cme program of Ccdsi. And today I must compliment and congratulate for choosing the very common but very important topic for physicians and clinicians, because we all know that diabetes, hypertension, and dyslipidemia are so commonly seen comorbidities in our day-to-day practice. In our clinics, we every third or fourth patient we see is suffering from either from hypertension, diabetes, and most of them are dyslipidemic. The what ICCMR report says that 80%, more than 80% are suffering from dyslipidemia. 30, every third patient is suffering from hypertension, and every fourth or fifth patient is suffering from diabetes and pre-diabetes. So it's a very bad scenario, and I think a very right topic to be discussed in this such a important meeting and on an important platform like CCDSI, so that we all are aware to investigate a patient, whether he comes for hypertension, must investigate for blood pressure, lipid. Any patient of diabetes must be investigated for blood pressure, dyslipidemia. So, and every patient of dyslipidemia must be investigated for hypertension, diabetes. So I think we have got a very very good speakers, Dr. Srinivas Murthy, a very learned speaker, Dr. Daria, Dr. and chairpersons, Dr. Princey Jain, Dr. Santosh, Dr. Ashok Taneja, Dr. Ashish Saxena. They are all persons. Moderators are Dr. Shankar Sen and Dr.
Gupta.
Smita Gupta. So I welcome all them, and I hope this online CME will make us more better. We will understand about all these important risk factors for cardiovascular disease. And it's my pleasure to welcome our founder president, Dr. Rai, and Dr. Virmani, Dean. Thank you very much.
So for the first talk, I request our moderator, Dr. Smita Gupta, to kindly introduce the speaker and chairperson and start the topic.
Thank you, Mrityunjay sir. Uh, Good evening, respected seniors, colleagues, and friends. It is my great opportunity to be part of this e-webinar, and we'll start our first session topic. And I would like to welcome our panelists and chairpersons, Dr. Princey Jain. She is Professor of Medicine in Lady Hardinge Medical College, Delhi, and is also Secretary CCDSI Delhi chapter. Our second panelist chairperson is Dr. Santosh Swain. He is Associate Professor in Puri Medical College, Odisha, and also Secretary CCDSI Odisha chapter. I welcome Dr. Princey and Dr. Santosh, and I would like Dr. Princey to please introduce a respected speaker. Dr. Princey.
Good evening, everyone. It's my pleasure to be a part of this CME today. And it's my privilege to introduce Dr. Daria sir. He's a distinguished clinician and an educator. He's a professor at National Institute of Medical Sciences and Research at Jaipur. And he has contributed enormously to diabetes care in India. He's served as a governing member of national bodies such as API, CCDSI, and Rajasthan RSSDI, and he holds a role of secretary of ACP India chapter and treasurer to multiple national and state professional bodies. He has also contributed as an editor and associate editor of several national monographs and as author in Medicine Update and RSSDI Update. And his expertise is recognized internationally and nationally by multiple fellowships, including FACP, FICP, FRCP, FIACM, etc. So it's our honor to have him here today for this talk. Please welcome Dr. Daria, sir.
Thank you so much, respected chairperson, Dr. Princey, for kind introduction. And at the outset, I would like to thank our founder chairman, Dr. A.N. Rai, sir, and President Dr. K.K. Parikh, sir, all the esteemed the chairman, scientific committee, including Dr. Lohani, sir, and Dr. Mrityunjay, Dr. Abhishek, and everybody, and the dean, Dr. Virmani, sir, for giving me this opportunity. So I think this is my the second inning. But last time I was also in the traveling in Kota, but today I had to do this. So I decided that I will do it from the car only. So I am here to in front everybody. So I'll be discussing on the diabetic dyslipidemia, basically of the Indian guidelines, right? So why we are worried about the dyslipidemia, as this slide is showing that diabetes is around 100 million people, but the dysglycemia, the dyslipidemia, almost the 2.5 times. So if we talk about the Indian population, there is a 1 in every 3 Indians with diabetes is living with the dyslipidemia, and that is a dual metabolic threat to everybody. So the lipoprotein changes in diabetes, especially the LDL, the quantitative changes are nothing, but slightly increase. But the qualitative, there is a high proportion of small dense particles and increased oxidation glycation And the metabolic changes, so there is a, because of this high proportion of small dense particles, there will be a decreased catabolism. And HDL is also decreased in concentration in diabetic patients, and there is a qualitative changes, the glycation is increased, and because of that there is a increased catabolism. The VLDL will do that, increase plasma VLDL, and mainly the proportion of larger particles of VLDL, and there is increased production of decreased catabolism. So this is the changes in diabetic patients, and this is the ADD, atherogenic diabetic dyslipidemia, and this is classical triad where the elevated TG, the low HDL, and the small dense LDL particles. So why we are behind the LDL? Because LDL is having a causal relation of atherosclerosis, and this Mendelian randomization studies and some other prospective cohort studies, they says that there is a connection between the ASCD and the LDL. So LDL is the mother cause of your ASCVD. Diabetes is a coronary heart disease equivalent. So what we should interpret, the diabetes alone carries a cardiovascular mortality risk which is comparable to that of prior myocardial infarction in the non-diabetics. So the clinical implication is that we should treat diabetes as a coronary heart disease equivalent. So that is why aggressive CV risk management, including the lipid profile, the blood pressure, and the glucose in diabetics, as crucial as in the post-MI patients. The cholesterol treatment trialist collaboration, which reported that once you are going to reduce the LDL 39 milligram per deciliter, or in the millimole it is 1, lowering of your LDL cholesterol, then you can reduce the atherosclerotic cardiovascular disease by 22%. So that is why it is so important to reduce the LDL cholesterol. So in diabetic dyslipidemia, as we discussed, that there is a high TG, the HDL is low, and small LDL particles. So which drug we have to give in these patients? This is the algorithm for diabetic dyslipidemia, where the statins are the cornerstone of the treatment. So if somebody is having a diabetic dyslipidemia, then always we have to keep the blood glucose under control with the LSM, lifestyle modification. And then the pharmacotherapy, if elevated LDL or mixed dyslipidemia, start with the statins. If someone is intolerant to the statins or there is an LDL target not achieved, then you have to add the first ezetimibe, and then if it is again not controlled with that one, then you can add the PCSK9 inhibitors, second line. Or you can add the fibrates, niacin, the bempedoic acid, inclisiran. And if there is only hypertriglyceridemia is increased, isolated, LDL is absolutely normal, then directly we can add the fibrates and the omega-3 fatty acids. So this slide is showing the different types of statins we are having in our armamentarium, like lovastatin, Preva, Simba, Atorva, Rajua, and pitavastatin. But the LDL cholesterol reduction is clearly seen in this slide, that the rosuvastatin, by giving 20 milligram, the largest or the maximum benefit in the LDL. But the 20 milligram rosuvastatin is almost as per as the 80 mg of atorvastatin. So we have to give much more higher dose in atorva rather than giving in the rosuvastatin. Then this Jupiter trial, where the treatment with rosuvastatin was given, and that significantly reduced the primary composite endpoint by 44%. So overall, the study says the rosuvastatin is better than the placebo group and other statin groups like atorva, the Simba, the pitavastatin, as per the Jupiter trial. And in this HOPE-3 trial, where the CV risk reduction with rosuvastatin in intermediate risk patient without any cardiovascular disease, and in here you can see that this rosuvastatin was having much more effect to reduce LDL cholesterol. It was also reducing the apolipoprotein B, and there is long transformed CRP also was reduced as compared to the placebo. in HOPE-3 trials. So what should be the LDL cholesterol goals in a CV risk patients? So this, as per the European Society of Cardiology, now you must be aware that earlier we were using the HEART score, HEART, HEART score, but nowadays the European population is using the score 2 or score 2 OP. OP is for the older people. So according to that score, there are a few things like the age, the family history, the lipid levels, the smoking history, alcohol history. So on the basis of that score, if it is less than 2% of score 2, then patient is of low risk. And the class second be indication to keep the LDL cholesterol less than 116 milligram per deciliter. But when this score 2 OP is goes high, more than 2 to 10%, patient is young, type 1 diabetic is less than 35, and in type 2 less than 50 years, with the duration of diabetes less than 10 years without the risk factors, then it comes under the moderate risk. And second class say that we have to keep the LDL cholesterol below 100. So same like on the basis of different moderate risk, high risk and very high risk, we have to keep the LDL according to that class only. So in extreme high risk, where we need to keep the LDL less than 40, those patients who have ASCVD and experience the recurrent vascular events while taking maximally tolerated statin-based therapy, and with polyvascular, including the coronary and your peripheral arterial disease. So in this type of patient, then the indication says class B, that we have to keep the LDL cholesterol less than 40 milligram per deciliter. So this was about the keeping LDL levels. Now, when monotherapy is not enough, then the rationale for combination therapy, mostly people fail with the single therapy or statin monotherapy to reduce LDL cholesterol by 70. So as per recent 2025 European Society of Cardiology guidelines or the ED guidelines, this says that we have to start the combination therapy when LDL targets remains unmet. So this is the second drug when they aid in ACT study. This study was to added the added rosuvastatin with the ezetimibe, and the in second arm they have uptitrated the rosuvastatin. But the both combination, they says that the LDL cholesterol below 70 milligram per deciliter was improved in the second arm where the ezetimibe was added on the rosuvastatin. Then the bempedoic acid in this cardiovascular outcome study in intolerant patients, when they have added the bempedoic versus the monotherapy, those who are not taking the statins or unwilling to taking statins, this bempedoic acid was uh, comparable to reduce 22% of your LDL cholesterol and MACE 4-point reduction by 13%, and the diabetes, there was no change in the blood sugar levels. Now come to the PCSK9 inhibition. They reduce LDL cholesterol, and how they reduce? There is a PCSK9, but they reduces the LDR, the LDL receptor recycling, and by receptor recycling, there is a increased plasma LDL cholesterol monoantibodies which act against the PCSK9, which is important in reducing LDL cholesterol by the 60%, and they decrease cardiovascular events, and it is approved by the FDA and EMA. There is a different type of PCSK which can be used either the monthly or the bi-monthly. Although it is a very costly, but people whose triglyceride or the LDL are very high, then in that in some patients you can use that one. So there are different type of newer PCSK9 target therapies. The monoclonal antibodies, the like evoclomumab and alirocumab, they can be given every 1 to 2 months or then for 12 weeks. They inhibits basically circulating PCSK9. Then there is a single stranded RNA. They inhibits liver PCSK that can be given every 6 monthly. The brand name is inclisiran. Then recombinant fusion proteins, they lirodel CPEP. Then oral peptides, they can be given orally daily. There is N-clicitide and leprostate. There are epigenetic silencing, and there are CRISPR-based gene editing, which is under the trials still. This is very good slide. So even below LDL cholesterol target, should we go for further LDL reduction? So what they say is that a quarter of a century of treating LDL cholesterol, high is very bad. We know that thing. Average is not good. Lower is better. Even lower is even better, but lowest is the best. The recent lipid association guideline says that you can keep your LDL check as low as you want. So even in the less than 30, you can go, then it is better. Few about the long-term safety of the PCSK9 inhibitor, evolocumab, where they have seen that it is safe to have LDL 30 milligram per deciliter for 8.4 years in comparison to the placebo. This slide is showing too that how the single, the double, and the triple combination of LDL cholesterol will be reduced by the different type of the statin or the combination. So you can see if you are giving somebody the moderate intensity statin, then it will reduce only 30% of your LDL cholesterol. If you are giving the high intensity, then it can goes up to the 50%. Single ezetimibe will only 20, the bempedoic only 20. So you can say the highest maximum achievement of your LDL cholesterol reduction up to 86% by including all the high intensity statins plus ezetimibe plus bempedoic acid and the PCSK9 monoclonal antibody. So if you are getting all these, then you can achieve the more than 86% of your LDL cholesterol reduction. So recent guideline of 2020 ADA, this says that in people who are 20 to 39 years of age, consider statin therapy if there are additional ASCVD risk factors. But between 40 to 75 of age, you can use the moderate intensity statin therapy in those without ASCVD risk factor. You can use bempedoic acid for those who are statin intolerant, and you can use the high intensity if there is a more than one risk factor of ASCVD with an LDL cholesterol goal of less than 70 milligram. And people who are more than 75 year or geriatric population, then you can continue the current statin therapy or consider initiating a moderate intensity statin after the weighing benefit versus the risk as per the ADA 2025. So this all we have talked about the LDL. But now what about the triglycerides? So triglyceride having a causal risk factor, this prove IT-TIMI 22 trial says that if triglyceride is more than 150, then there are higher chances of your cardiovascular disease in statin patients with LDL less than 70. Even LDL is your less than 70, but still you can, TG is high, then you have the CSD risk is high. So these are the causes where the triglyceride is increased. The primary cause is genetic, but the mostly increase in the secondary causes. These are the list of secondary causes where the hypothyroidism, diabetes itself, if it is poorly controlled, can increase your triglyceride. Obesity, some nephrotic syndrome, autoimmune disorders, HIV, associated dyslipidemia, and the third trimester pregnancy. Few drugs also increases triglyceride levels like beta blockers, thiazides, steroids, the SERM estrogen receptor inhibitors, estrogen, the PI, sirolimus, bile acid resins, and some antipsychotics. Alcohol, excess alcohol causes increase in triglyceride. Positive energy balance diet with saturated fat and high glycemic index load is also having the increase in high triglycerides. So don't forget, although patients with diabetes have a higher triglyceride level compared with patients without diabetes, and LDL lowering is still the first priority in treating diabetic dyslipidemia. Non-pharmacological interventions are the background for managing dyslipidemia and diabetes, but statin therapy is additionally indicated for all patients with the diabetes. So these are the recommendations as per the European Society of Cardiology, that total cholesterol is to be used for estimation of total CV risk by means of the score system only, that is available in US, and that is a online risk calculator. The triglyceride analysis is recommended as a part of routine lipid analysis with the class 1 and the level C indications. So this was all about the triglyceride and the LDL or the dyslipidemia and diabetes. Thank you everybody for your patience hearing.
Would like to give one comment on this. Hello.
Yes, sir.
Yeah, newer guidelines of testing of lipid profile by Lipid Association is you don't need to have 12-hour fasting. You can straight away check lipid profile unless and until you are checking only specifically for triglycerides.
What was the question?
No, it is a comment, sir.
What was the comment regarding triglycerides?
कि लिपिड प्रोफाइल को टेस्ट करने के लिए एज पर लिपिड एसोसिएशन यू डोंट नीड 12-hour फास्टिंग
करेक्ट
एक्सेप्ट व्हेन आप सिर्फ ट्राइग्लिसराइड चेक कर रहे हैं उसके लिए तो फास्टिंग जरूरत है अदरवाइज यू डोंट नीड फास्टिंग स्टेट
नॉन फास्टिंग इज गुड इनफ
यस गुड इनफ बिकॉज एलडीएल जो है जब आप चेक करते हैं तो डायरेक्टली आप नॉन फास्टिंग स्टेट में भी चेक कर सकते हैं
राइट
Very helpful in routine clinical practice, sir. For people who are traveling from farther distance, it is very very useful, and we should utilize that non-fasting sample for most patients.
Sir, Dr. Daria,
Yes, sir.
I have a query which is often asked in most of the conferences that in diabetic dyslipidemia, we have the classical atherogenic dyslipidemia where there is increase in the triglycerides, a decrease in the HDL, and a normal LDL, but increase in the small dense LDL. Now, the question often asked is, if triglyceride is the major concern, why do we treat LDL first and not the triglycerides?
So the first slide I showed you that the LDL is having a causal relation with the atherosclerosis. So when there is a plaque formation, so LDL is more pathologically involved in that more than the your TG. So what happens in hypercholesterolemia? There is LDL through the transcyclic route that is trapped under the suboptimal space of damaged endothelium, and that goes to oxidation, and by the oxidized there is a oxy LDL, and this oxy LDL which is engulfed by the macrophages, and that in forms the cholesterol form cells, cholesterol laden form cells. And because of this cholesterol laden form cells, there is a inflammatory signaling pathways which are activated in form cell, and they lead to more cell recruitment and plaque formation. So that is the reason that we have to treat the LDL rather than the TG. Because of oxidation of this LDL, oxidize cholesterol form cells and they recruit more and more. Then there is a inflammatory signaling pathways involve activation, plaque formation, and we know that plaque is the main what we want to reduce that formation.
So one question.
Sir, I have got one query. Can I ask?
Sure, sir. Answer
Dr.
will be given
Daria,
by very
excellent
sir.
talk. How are you?
I am fine, sir.
I just wanted to know, suppose a patient is having LDL 150, triglycerides 250, cholesterol 250. So what should be the starting dose of rosuvastatin? Number one. Number two, you had mentioned that beta blockers causes rise in triglyceride. So is there any specific beta blocker or are you mentioning for all beta blockers?
No, not all beta blockers.
Yes.
There are some special the beta blockers, including the propranolol and some others. I have seen only few data regarding that, and the important is the propranolol and one other. I'm forgetting the name of that one.
So they cause increase in triglycerides, you mean?
Sometimes
Propranolol.
because because every drug is having a side effect. So it is not like that if you are giving that, then, but of course, like we are, if you are giving a monosef, then there may be chances of thrombocytopenia, but it is not routinely causing. So in causes, everything we are including. So there's sometimes the beta blocker can also cause that one.
And what should be the dose of rosuvastatin? My first query. Starting
20
dose.
mg at least. 20 mg.
Okay.
Can I comment here? Dr. Daria, can I comment here?
Sure,
Yes,
sir.
sir.
Okay. Now, the question asked by Dr. Arya regarding LDL of 166, what to start and what not to start, it is simple mathematics. You have to first look at the patient and decide whether he is mild risk, moderate risk, high risk, very high risk, extremely high risk. Once you have taken that decision, you should know what is the target LDL. Suppose the target LDL is less than 70. We all know. Can somebody mute? Somebody is talking on the phone. Please mute. Then after that, you have to first see that what is the difference between the present LDL level that the patient has and the target that you want to achieve. Now we know that 20 milligram of rosuvastatin will lead to only 20 to 30% reduction in LDL. So you are not going to achieve the target with 20 to 20 milligram of rosuvastatin. So you have to have an early combination therapy. Maybe in such a huge difference, I would start with 20 milligram rosuvastatin, bempedoic acid, and ezetimibe, all three together to achieve a reduction of almost 70 to 80%, if not PCSK9, which is injectable, costly, and we have to keep it in the hand. I've had patients in whom I have started these three drugs right from day one with a wonderful result, and it is now being recommended also as triple therapy by the LA.
Sir,
So actually, I
after
forgot to show you
starting
this
this
slide.
triple therapy, after how long would you like to review the patient?
Minimum 3 months.
Sir, I will like to ask, like you said, this triple therapy, why not to start rosuvastatin 40 milligrams in these type of patients and bring down the LDL fast?
Sir,
See,
this slide is slide of answer of all your questions as per the 2022 Lipid Association of India recommendations for managing the diabetic dyslipidemia. I forgot to show you this slide. Here you can see that how much we have to add and since how long we have to remonitor. Everything is written in that according to this, if there is a no target organ damage or less than one SCVD risk factors, it comes under the high risk group. If LDL less than 70, non-HDL less than 100, ApoB is less than, then start the high intensity or the moderate intensity.
See, starting with 40 milligram of rosuvastatin is going to cause more adverse effects than starting with a combination of 20 milligram rosuvastatin plus ezetimibe. So we have also to look at the tolerance and the adverse effects. So it is better to have two drugs with complementary mechanisms and reduce the adverse effects and get a better target.
Agreed, agreed.
Sir,
I
sir,
100%
I will like to make one more point.
Yes, Dr.
In
Nandi.
diabetic patients above the 60 years of age, sarcopenia is very common. If you start 40 milligram of rosuvastatin, it is going to make the muscles worse. It is
Correct.
better to use two drugs rather than one single drug in high dose.
So the target, today the saying is it is not actually high intensity statins, it is high intensity lipid lowering. So you start with early combination therapy to achieve your target.
Sir, I have a query, sir. Can I ask one question? Dr.
Yeah.
Vimani, sir.
Yeah.
Sir, if we want to go for combination therapy, suppose if you want to go for combination therapy of two drugs, statins plus ezetimibe or statin plus bempedoic acid, in your clinical practice, which combination you prefer most and why?
I usually start with statins and ezetimibe combination depending on the target level to be achieved. If I'm not able to achieve the target level in 3 months, I add bempedoic acid, provided I'm sure patient has been taking that drug.
Sir, you are preferring as a statin plus ezetimibe over statin plus bempedoic. Why, sir? Uh,
See,
just a query.
statin plus ezetimibe is available as a single pill combination. It is easier to start. It is more affordable than adding bempedoic acid, which is much more costlier. So you have to keep bempedoic acid as a reserve for patients who do not respond to statin plus ezetimibe.
Thank you. Thank you, sir.
For affordability and for easier adherence, because you're giving a single pill. There you will have to give two drugs separately.
Sir, how do we treat in, like, what do we do in pregnancy, special situation?
Pregnancy, statins are contraindicated.
Yes.
Absolutely. The only drugs that are recommended are bile acid sequestrants, but then again, it can lead to another problem of nausea and vomiting as it is there in pregnancy. So you have to take a decision, share-making decision with the patient. If the LDL is very high, there is familial hypercholesterolemia, or there is history of premature coronary artery disease in the family, then perhaps you will have to put her on the bile acid sequestration. Otherwise, you have to wait till the pregnancy is completed. There's
Okay.
no option.
And so what should be the cutoff level for triglyceridemia to treat in pregnancy? Because
5.
there will be slight increase in the triglyceride levels in pregnancy also.
Then turn
So
left.
300.
See, the treatment of triglycerides is a very tricky issue. Actually, if you look at the pathophysiology, triglycerides per se are not the culprits. It is the triglyceride remnants, the cholesterol remnants. That is why after reaching the target of LDL, we look at non-HDL. And non-HDL includes everything except HDL, right from the cholesterol remnants to VLDL to LDL to triglycerides. Now, we normally should not be treating triglycerides from 150 to 500 in patients who do not have any atherosclerotic cardiovascular risk. You treat more than 500 with fenofibrate, saroglitazole, or icosapent just to prevent pancreatitis. But in patients who have a triglyceride of 150 to 500 and have a high risk of atherosclerotic, family or established ASCVD, then you put them on icosapent ethyl.
So I'm asking in pregnancy, sir, what should be the threshold of treating triglyceride in pregnancy?
300 milligram. 300.
Yeah. I think
Cutoff is 300.
Because there will be slightly raised triglyceride in pregnancy also.
Dr.
Many
Lohane,
patients.
give a talk on dyslipidemia and pregnancy. Dr. Lohane would like to give you expert comments.
300. The cutoff is 300. In pregnancy, triglyceride cutoff is 300.
Correct.
Total cholesterol 250. LDL 160. HDL less than 40. So this is the cutoff in pregnancy, which is slightly higher than normal person.
Absolutely.
I think Dr. Noni wants to comment. Dr. Noni, he wants to
Good
comment.
evening. Just one few points. Actually, Dr. Speaker was taking, saying 20 milligram is equal to 80 milligram atorvastatin. Probably that is mismatch. 40 is equivalent, Rozu is equivalent to 80 milligram atorvastatin. Regarding the non-fasting sample is used these days, the reason is that HDL is quite stable in the non-fasting state, but LDL and triglyceride can vary. But we can see the random for the usefulness. But only thing is that when you are seeing the non-fasting level, one has to look not at the LDL. One has to look at the total non-HDL. The target of total non-HDL, that is because LDL, what is the target of LDL? Plus 30 is the target of non-HDL. If triglyceride is high, then you have to repeat in the non-fasting. So that is my one comment. Second thing to what the Arya sir has said about the what dose of the rosuvastatin or this should be done. Probably it is not the dose 20 milligram, 10 milligram, 40 milligram. You got to risk stratification the patient, like the Birmani sir said, what conditions are there or not, anything other. According to the risk stratification, you got to add the dose of the statin. And the ideally, if I have to ask me, then I'll go for the single molecule first. If there is a not imminent or immediate, there is a risk. So one drug and the second drug should be ezetimibe and the third drug is bempedoic acid. That is the way of the guideline says. And regarding your this thing, one more thing what has been spoken, the triglyceride. The triglyceride level, one thing I got to point that one should be a little bit cautious while taking the triglyceride because all molecules have been mentioned by the Birmani sir regarding the fenofibrate and the lipaglyn, like this thing. But these two molecules should not be combined. You should, as far as practical, this molecule as because there is an increased chance of intracerebral hemorrhage. So you should avoid using this lipaglyn along with that this thing.
They should not be used together. They cannot be used together.
Yes, that's what, sir. That's what.
So, today the only
and
today
and moreover,
only indication of 80 milligram atorvastatin is acute coronary syndrome or after PTCA. No other indication for 80 milligram atorvastatin.
And one more thing that regarding the score, and Dr. Daria has said about the score of the score 2 and this thing. But important for Indians, this score is, I think we have to take a pinch of salt. Either we got to go for Curix 3, which has been done in the Indian population, or the lie has coming up the new for the Indian score. Probably that has to be that can be applied to the Indian population. So score 2 or whatever we may not accept right now, and you go to at all you go to look, you go to Curix 3.
Score 2 is not validated for Indians.
It's for European countries.
Cardiovascular risk. So the best score is Curix 3, but LAI is also developed a CVR score, and it is now in the testing stage, and very soon it will be available in your mobile app.
Right.
Sir, I think everybody is talking about the fasting and non-fasting. So give me just 1 minute. Where the fasting lipid testing is gold standard for the atherogenic risk assessment. Okay. It is highly sensitive to detect triglyceride levels, especially in patients with the insulin resistance, and preferably in certain high-risk patients or those with the severe hypertriglyceridemia for exact diagnosis and therapeutic monitoring. And preferably, it should be done if there is a known fasting TG is more than 440 and can be considered 2 to 4 weeks when known fasting TG is more than 200. Now, I will tell you about the non-fasting. Non-fasting detects the plasma lipid levels of both atherogenic lipoproteins of hepatic descent and those originating from the intestine. And it preferred in patients with diabetes due to the increased risk of hypoglycemia with the fasting. Low LDL lipoprotein cholesterol can be precisely assessed using modern techniques, and it reduces patient barrier for the testing and increases patient convenience and the compliance. Regarding the Q-risk 3, of course, Q-risk 3 is good for Indian population because it also includes the diabetes in the risk assessment, including age, including some other things like systolic blood pressure. There is a smoking status, ratio of total cholesterol, BMI, ethnicity, family history, CKD, RA, AF. So that is for the Indian population.
So 8:40. Can we move on to the next session?
So I think for this session, we would like to thank Dr. Daria for such a wonderful presentation. And thank you, Vermani sir, Noni sir, and Parikh sir, and Rai sir, and Mrityunjay sir, and Dr. Abhishek for such organizing the CME and such an
Dr.
enlightening
Prince, there
discussion.
is one question in the chat box. Can we take that?
Yeah, sure.
So this is for Dr. Daria sir. 25 years old patient, LDL 166, triglyceride below 200 and non-diabetic, non-hypertensive. Should we start statin or look for risk score? Just quick one from Dr. Daria sir.
You're muted, Dr. Daria, you're muted.
So we have to look for the risk score, and then if it is 20% non-diabetic, if there is a family history of any CAD or something else, the status can be started in more.
Okay, thank you, sir. Thank you so much.
I think it is already discussed.
Yes, already discussed.
Yes,
Over to
already
Dr.
discussed.
Princy.
So I think we'll wind
So
up
we
this
can,
session. So thank you, Varmani sir, Parikh sir, Rai sir, Taneja sir, Dr. Mrityunjay sir, and Abhishek sir for this highly
thanks to all of
enlightening
you,
session
but
and clinically relevant topic.
stay connected. We are going to
Sure,
have
sure.
the
Next
second
time.
masterpiece talk. I would like to request the moderator, Dr. Sankhasan sir, to introduce our chairs, Dr. Taneja sir and Dr. Ashish Saxena sir. And thereafter they will introduce the speaker sir and conduct the session.
Thank you. Thank you, Dr. Abhishek. It's a nice opportunity because after the talk on dyslipidemia, which had a high question answers also because we had a nice discussion. So the next topic is on something which is very close to our heart, that is hypertension and diabetes. Will be none other than by Dr. L. Srinivas Murthy from Bangalore. But to introduce him, may I first introduce the chairpersons of this session. Dr. Ashok Taneja sir doesn't need any introduction in this part of our of the world, and he is the past president of the Ccdsi and the president-elect of API. Along with him is Dr. Ashish Saxena, who is the secretary of the Ccdsi Punjab chapter, and he is a very well-known physician with more interest in echocardiography and also certain fellowships in diabetology and cardiology and also in all over like internal medicine. So both of them are very well suited to chair this particular session by Dr. L. Srinivas Murthy. May I request Dr. Tanaja sir and Dr. Ashish Saxena sir to introduce the speaker and also have your introductory remarks. Thank you.
Yeah.
Good,
Should I start?
good evening, everyone. Today's topic, diabetes and hypertension. It's a dual killer, and I will name it as one is Ravan, another is Kans. So combining together the both, the risk of morbidity, mortality, and organ damage increases. Dr. Ashish, please elaborate further.
Yeah, it is very rightly said, sir. It is a deadly combo of diabetes and hypertension, and almost it is a mask disease. We have a very good speaker, Dr. Srinivas Murthy, who is a triple FRCP, Vice President of National RSSDI, and a Governing Council member of Central API. He has several orations which he has been awarded because of his intellectual skills. A very nice organizing secretary for ACP India in Goa and Vizag. He has got a lot of national, international publications, as well as he is a very nice and an ace clinician and researcher because he has been able to work with US FDA twice and has done a wonderful job. So, Dr. Srinivas, we know that diabetes and hypertension is one thing which is very common in our patient population. We're looking forward to your clinical insights and what new is there in hypertension and diabetes because we are having lots and lots of patients with a blood pressure of 144 or 146 by 96 apart from taking dual therapy or a triple dose combination. And especially I like to ask you while your dissertation about what will be the role of hydrochlorothiazide or chlorothalidone, because in one part of the world chlorothalidone is very common and one part of the world hydrochlorothiazide, and what will be the effect in our Indian population. So over to you, Dr. Srinivas.
Thank you, Ashish and Taneja sir. I think it's a homecoming for me and talking among the family members. It is like that with A.N. Rai sir, Parek sir, and Virmani sir. And thanks to Loani sir to give this topic and to talk about the hypertension and diabetes in the Indian context. That was the topic given to me. And these are my disclosures. And to start with, this is going to be the agenda, the burden of escalating hypertension in the Indian context, and evaluation, diagnosis, and of course, approach to the pharmacotherapy of hypertension. So the burden, the status of India with respect to the hypertension is about 230 million adults who suffer from hypertension in India, out of which more than 50% of them have uncontrolled BP. This is the data which is available. And remember, 10% of rural Indian hypertensive people and 20% of the urban hypertensives have their BP under control. That means literally 80 to 90% of the patients do not have their control, and whenever it comes to the standard of care. And this hypertension results with about 1.6 million annual deaths, which accounts for about 10.8% of the mortality, 4.6% of the disability adjusted life years in India. So that is the burden with which we are treating our patients, and the achievement of the goal with 10 to 20% hardly, the onus is completely on us. The clinical inertia of not up-titrating, not adding on the app drugs is something which we should look at. So of these estimated 230 million odd patients, 12% have their under control. This is another paper which is from India again. And this uncontrolled BP is the main risk factor for CVD, all of us know. And this is the most common cause of death and disease as far as the CVD is concerned. And CVDs are also responsible for about 1/3 of the total deaths in India. So the hypertension is indirectly the major contributor for these 1/3 deaths which occurs due to CVD. And look at this slide which talks about the last 4 decades, how the increasing trend in hypertension prevalence in the urban, the top panel, and the bottom one is a rural. You can see literally it is growing up from years on year. And that is something which we should be worried about. The prevalence is increasing. And we have some peculiarities of hypertension in India, where we have an early onset, the rural-urban divide, clustering of various risk factors, significant seasonal variation, rising average BP in general population, and of course, low awareness, and the target is not achieved in many of such patients, wherein they end up eventually with a hypertension-mediated end organ damage. Now, let's look at the global perspective. By 2040, diabetes will be prevalent in 10% of the world's population, out of which 50% of this will be in the Southeast Asia or APAC region, what we call. And the combination of diabetes and hypertension, you can see there is about 250 million subjects. That means 1 out of 2 patients in diabetes also suffer with hypertension. So that's something which is the importance of treating this dual menace in our routine clinical practice. So hypertension, remember, is twice as frequent in patients with diabetes compared to those who do not have diabetes. So that means literally every other diabetic, we need to be worried about hypertension part. And this is a natural history of diabetes. We all know that the complication starts off much earlier than the disease manifests. And this can be another slide which talks about the hyperglycemia and the tissue lesions, complications which results much ahead of diagnosis of diabetes. What you should know is that diabetes is associated with a significant loss of years. That means on an average, a 50-year-old individual with diabetes without history of vascular disease will die 6 years earlier compared to somebody without diabetes. And when you combine this with hypertension, you can imagine the complication. So the excess CV risk in diabetics is attributed mainly to the coexistent hypertension. So the all-cause mortality can worsen by about 72%. The cardiovascular death or the MACE events, what we call, is exaggerated by 57%. So the poor control rate is seen in patients with the hypertension and diabetes. So 44% of the patients remain uncontrolled despite the antihypertensive therapy. 1 out of 2 patients do not achieve. That means the patients are about 7 times more likely to remain uncontrolled due to non-adherence to the medication. This is what we were discussing even in the earlier topic as well. So let's look at the evaluation and diagnosis of hypertension quickly. This is an unmet gap in hypertension, which is reflected by this NEHAN study, where about 40% of the subjects were unaware of their hypertension, 16% were aware, but not currently using any medication. And this is the scenario even in our setup. I'm sure all of us will encounter these patients in our routine OPDs where they say my BP is 140/90 from 3-4 years, sir, but I'm maintaining at 140/90. I'm not allowed it to worsen it. And about 44% were aware and being treated. That means literally half of them are not aware, and in that about 15-20% will not be on medications. Now let's look at this India Hypertension Control Initiative, which is a high impact and low cost module by WHO. This is called India Hypertension Control Initiative, where they had a multiple partner initiative with the Government of India, Ministry of Health, ICMR, and WHO, and resolved to Save Lives, which is a technical partner. Basically, that set a target of 25% relative reduction in the prevalence of hypertension by 2025. To achieve this, it is important to fast track access to treatment services by strengthening interventions such as this a model of India Hypertensive Control Initiative. What they did is they picked up a cohort of about 21,000 plus patients in about 24 sentinel sites in 4 Indian states, includes Punjab, Madhya Pradesh, Maharashtra, Telangana, and there is a registry between 2018 to 2019. Among all the registrators, about 51% of the patients returned for follow-up between this period, and among these who returned, 26% had BP well controlled at registration, 59% had BP controlled at follow-up with a standard of care. So what did this show us is that absolute improvement in BP control was more than 2 times greater in the primary care setting than secondary care facility. I mean, this is a very, very good lesson what we learned, the data which clearly showed. Remember, the improvement is better with the primary care than the secondary care. And these patients received prescriptions according to the state-specific treatment protocols. It was not something a uniform module because state health is a state policy. So the study demonstrated that a scalable public health hypertension control program can yield a substantial BP control improvement, especially in the primary care settings. However, high loss to follow, because if you see about 60% of them are lost to follow, this limits the population health impact, and the future efforts should be focused on this, improving systems to increase this likelihood that patients will return to the clinic for routine hypertensive care. And then let's look at the approach. Our goal in India, especially, it should be to prevent, reverse, or delay the complications. That is all is our goal, and reduce the overall risk without adversely affecting the quality of life. So the patient should be explained clearly about the lifestyle interventions, the drug treatment, which are lifelong, that should be emphasized, and compliance to both the lifestyle and the treatment therapy is very, very important. This is what we need to emphasize whenever the patients come to us in our routine clinical OPDs. So let's look at the adherence part, which is a pressing issue in most of our conditions. Now, if you see in this trial, the risk factors for non-adherence to antihypertensive, they showed that when somebody is on 6 or more drugs, about 80% of them are non-adherent. And this is highly prevalent, especially in patients on multiple drugs. This I'm just showing you with the evidences, the published data, that the suboptimal adherence, a recognized factor for contributing to the poor BP control. Another one, the SPC, that is the FDCs, antihypertensive medication added to the WHO essential medication list, which is important. And the SPCs enable more patients to achieve targets BP with long-term CV protection. The single pill combinations or the FDCs are very important to reduce the pill burden. So remember, 6 or more drugs is equal to 80% non-adherence. That means they skip the antihypertensive or the lipid lowering agent. Like in city like Bangalore, learned people, IT people say that every weekend I don't swallow the statins. No, that is the extent people avoid due to pill burden. Now let's look at the hypertension treatment cascade in India, which are results from the non-communicable disease monitoring survey. This was basically to estimate prevalence, awareness, treatment, and control of hypertension along with determinants in India. The data was from the National NCD monitoring survey between 2017 and 18, was used to study the one adult from a representative sample of households across India and collected information on socio-demographic variables, risk factors for NCDs, and treatment practices. I request Ccdsi, now the current President Parikh sir, we can do something of this model in through our banner of Ccdsi, which will be very helpful, sir. We can simply copy this module and bring out our own data with this with a huge numbers, because we have members across the country now, and we have a lot of state chapters also. So the blood pressure was recorded digitally. Hypertension was defined as 140/90. Awareness was defined as being previously diagnosed with hypertension by a health professional on treatment as taking a dose of medication once in the last 2 weeks. Control of BP less than 140/90. This is all is what they looked at with 10,000 plus patients. And what did they saw? The total males were 5,490, about 99%, and females, this was the urban adults. And of the total adults, 28% were found to have high BP based on their BP measurement, which is just one cross-sectional data. And of them, 28% were aware of their hypertension status, 15% were under treatment for hypertension, 12% had their BP under control. So eventually it boils down to only 12% of them were under control. You can see out of 100, 30% aware, 14% or 15%, half of it, the rule of half, you can say on treatment, out of 14%, good control is only in about 12% of the patients. So this is what they could find out, and this is the awareness, prevalence, and the treatment target what our people have. So to conclude, in this study, the hypertension control was poorer among urban participants, not the rural, urban participants. Significant regional differences were noted through, though without any clear trend. 1/5 of the patients were being managed at a public facilities. Again, this was proved in COVID also, that the public facilities are the primary care physicians are the backbone of in our country for this health. And the poor population level hypertension control needs strengthening of hypertension services as a universal health coverage package. Now let's move on to the initiation of therapy now. In patients with stage 1 hypertension, repeat readings should be taken every 2 to 3 weeks following LSM, that is lifestyle modification. The pharmacotherapy should be initiated after failure of the lifestyle modification, which the non-pharmacological therapy we don't emphasize in our routine clinical practice for various reasons, but it is our duty to emphasize the importance of LSM in the treatment therapy, in the treatment cascade. The BP should be recorded, both arms, lying, standing, before initiation of pharmacotherapy. Choose the arm which has got the highest usually and follow that same arm, what we do in clinical trials as well. Patients with stage 2 or 3 hypertension, a shorter waiting period, that means to initiate the pharmacotherapy can be very quick, depending on the risk stratification with other comorbidities and the risk stratification, the risk scorings are available. And in those who have evidence of end organ damage or a target organ damage like a fundoscopy, ECG are basics which you should look, or microalbuminuria, you need to initiate the pharmacotherapy immediately. So this is the Indian guidelines for the definition of hypertension. Anybody above 18 years, 140/90 is supposed to be taken as hypertension. And there are classifications which are optimal, normal, high normal, and stage 1, 2, 3. And isolated systolic hypertension is only available in the Indian guidelines as grade 1 and grade 2. In other ESH and EAC, it is only 1, which talks about the 160/90, and that is what it is. In Indian guidelines, we have two classifications of ISH, that is isolated systolic hypertension. Grade 1, 140 to 159, and grade 2 is beyond 60, and the systolic should be less than 90. Now, again, the blood pressure values for diagnosis, hypertension in different methods. Indian guidelines, again, I'm quoting, office BP 140/90. Of course, home BP, remember 135/85. Ambulatory BP is again mean value, matches with your home BP monitoring 135/85. And if it's in ABPM, the night mean should be 120/70 and above. 24 hours should be 130/80 and above. Let's look at now the individual drug classes based on the guidelines and clinical studies. The evidence is what we show. This talks about the all evidences on the right hand side, the great trials which we had, because of which we are using these drugs. On the left hand side, you can see the compelling indications, and in the middle, you can see the diuretics, beta blockers, AS, ARB, CCB, and aldosterone. And this is what you need to choose in the background of heart failure. This is the class of drugs which can be there. Post-MI, again, the class of the beta blockers is one niche indications now with all the guidelines. The beta blockers are used specifically post-MI. And of course, high CVD disease, again, like diabetes, is one of the conditions where there is stratification, the level goes to the severe form with just presence of diabetes. And this is what you can use, the diuretics, beta blockers, ACE, and CCBs. CKD, ACE, ARB are CCBs. And recurrent stroke prevention, diuretics, and ACE and CCBs. I think our chair, Dr. Ashish, good friend, asked about the type of diuretics, and all these they've used the chlorthalidone, and the evidence exists for that. Though in our country, for example, we use more of ARBs, though the evidence all leans towards the ACE inhibitors. So that is something which is there. But when you talk about the evidence, this is what I told you about the ESH ESC guidelines 2024. Initial therapy, they now start with one pill, that is a single pill combinations, SPC is what we call. So the monotherapy is hardly used now. So hit hard, hit early is the principle. AS or ARB is a must. CCB or a diuretic, that is what you choose. Step 2 would be the triple combination, wherein you combine the ACRB plus CCB plus diuretic. And of course, step 3 is spironolactone MRA, which you add in a resistant hypertension, which you can consider and also look at other reasons. As I said earlier, beta blockers now have become a niche for heart failure, angina, post-MI, AF, or young women or men blacks. This is what we look at. And this is an algorithm in Indian guidelines. They divided into younger and older, and this is 60 years, 55 years is the cutoff between young and old. And younger, you can see the A, and you can up titrate step 2 with ACRD. A stands for ACE or ARB, and C calcium and channel blockers and a diuretic. And this is how you go about. Older, you choose calcium or CCBs or the diuretics as the first choice, and not the ACE or ANH. Of course, if there is diabetes added, then scenario would change. And this is the initiation therapy in hypertensive patient as a flow chart I've just tried to show here, where in stage 1 hypertension, you need repeat readings, just like the International Society of Hypertension. 2 to 3 weeks you follow up, and then look at if the LSM fails, the pharmacotherapy can be initiated after about 1 month, and BP should be recorded, both arms. And this is what I was talking about, alluding earlier also. And with the evidence of existing HMOD, that is organ damage, you can definitely start off. And the BP should not be brought down at any time below 120/70. And that's something which hardly we achieve in our routine clinical practice, but that is something we need to keep in mind, especially when somebody is on triple drugs. The target BP should be more or less in most conditions with whatever the comorbidity is 130/80 among people who are less than 60, and up to 140/90 you can stretch beyond 60 years. This is there in Indian guidelines. So with hypertension and diabetes, the topic of interest, this does not change. Again, this remains same. This is the ESH ESC guidelines 2024. And again, it remains same as far as this, but 2 pills are in this resistant hypertension can be considered early to prevent the complications as far as these are. So most guidelines, when it comes to the recommendation, they combine ACRB or CCBs or diuretics for the treatment of hypertension in the background of diabetes along with a diuretic. Now, some things which we should be aware about, what to avoid as a combination. Beta blockers, ACE inhibitors, try to avoid, but in certain conditions we are compelling to give. Beta blocker and centrally acting drugs, beta blocker and verapamil diltiazem, ACE inhibitors and ARBs never combine. And of course, the bottom line is 2 drugs from the same class, don't try to put it on. Now, I was talking about this earlier that, the ACE inhibitors have exhibited a lot of advantages versus ARBs. Of course, this is a burning problem always, but this is a meta-analysis I'm trying to show. Look at the numbers. They have considered the number of patients, and there was a statistically significant 10% reduction in the relative risk for all-cause mortality and a trend towards 12% reduction in the CV mortality. This is ACE versus, you can see all the clinical trials with ARBs and ACE. Advanced IVET trial was with indapamide elderly patients. That was the only trial which has shown a diuretic, and this is the evidence which I was talking about, Dr. Ashish, about the advantages why you should use the indapamide or the chlorthalidone. These are the studies which has got in favor of that for using them. And significant reduction in CV and renal points, and this was the advance on trial which was with diabetes, 11,000 plus patient, one of the longest trials, one of the earliest trials, a decade earlier or 2 decades earlier. Primary endpoint, total renal events significantly reduced by 9% and 21%. This was all before all our SGLT2 and GLP-1 trials came. These were the trials which talked about diabetes and hypertension, and perindopril and indapamide is one of the things which were used molecules, and up to 5 years advance on hypertension with diabetes. And the triple nephroprotection was also seen in the same combination. And these are all the others which was shown, the worsening nephropathy, macroalbuminuria, microalbuminuria reductions were seen with this combination. It definitely works in clinical practice as well. And of course, the proof of vascular legacy was seen in advance, where the risk reduction was independent treatment and the BP patients with diabetes in advance on. That means even though the BP was and diabetes was combined, this beneficial effect was seen for the years of 5 years even after the study was ended, and this was additional 10 years follow-up. Those who are on placebo, you can see the risk going up, and those who are in the perindopril indapamide, the legacy effect continued. So this was one of the earliest trials which showed about the legacy effect, which we talk often about UKPDS. The advance on was something which was there. So these drugs had to be initiated early. And this is another trial called Progress trial, where again they showed benefits in the stroke protection also with the same combination. As you can see, 6,000 plus patients, and you can see various markers and the relative risk reduction with respect to the cerebral hemorrhage in ischemic strokes, fatal or disabling stroke, and this was exclusively done in the stroke reduction. And of course, this was a triple drug combination, perindopril, indapamide, amlodipine, and I was part of a clinical trial of this, and I was the investigator, and we had a JAPI publication of this, where in just about 14 days, and end of 3 months, look at the reduction by 30/15, systolic, diastolic respectively. This was the reduction, and this was a approval trial for this triple drug combination. This was published with JAPI, and we had a 90% compliance and 99% patient satisfaction score. How do you maintain after you initiate? Once therapy has been initiated, you need to be seen at frequent interval depending on the patient. 1 month, 2 months, or 3 months you can look at, but at least once in fortnight the BP should be measured at the clinic. Encourage them to buy a BP machine. I think post-COVID everybody accepting this home blood pressure monitoring, and the risk factors to be taken care. The comorbidities has to be equally given importance and treated, so that the overall risk stratification of the patients comes down along with the blood pressure, and the frequency can be reduced once the BP is settled, and that is what we should look at. Now, few words about the non-pharmacological interventions, which most of us do not emphasize when we treat hypertension. What are those? The weight loss part, eat heart healthy diet, sodium reduction, potassium supplementation, and look at the level of evidence. All is class A and level 1 recommendation. These are the recommendations by ACC/AHA, which most of us fail to emphasize, unfortunately, to our patients. And this is the worst thing which most of us do not follow, do not preach also. The physical activity to our patients with some resistance exercises, and of course alcohol part and the smoking, which we need to look at as emphasis, and keep looking at these columns which are level 1 and A evidence. That is something which is very, very important. And what are the best proven non-pharmacological interventions? You can see the body, the weight loss part, about 5 millimeters can be the impact on systolic BP with 1 kg reduction. So 1 millimeter is equal to 1 kg reduction. That is what the reduction you get. Of course, the DASH therapy, sodium less than, this is another big problem in our routine clinical practice because of our cultural practices. And of course, the potassium intake and the physical activity. Again, I'm trying to emphasize that the aerobic, dynamic resistance, isometric exercises, you can see the reduction 4 to 5 millimeters. And that is something which you should look at. So reducing the BP gives you more reductions with respect to the CV risk when compared to the HbA1c. We all chase HbA1c most of the times in a diabetic background, but 5 mm to 10 mm can reduce the risk by 50%. That is the CV risk what I'm talking about. That we should be aware about. And 90 to 150 minutes per week can give an impact of 5 to 8 millimeters of systolic BP reductions. So all guidelines clearly talk about the LSM, that is lifestyle modifications, which includes weight loss, physical activity, limiting the smoking. I would say quitting smoking, not limiting, and salt restriction, and of course, consumption of fruits and vegetables to have an impact on reduction in the blood pressure. And this is just to touch upon the lifestyle interventions as in the latest ESH guidelines, which is salt substitutes, increase potassium consumption, and add dynamic strength training, reduce stress, more stringent recommendations with regard to alcohol, and the alcohol should not be recommended for CVD prevention, and avoid excessive drinking to reduce the BP and the complications. So the algorithm to show for addition of drugs after you initiate with one drug, if the BP goal is achieved, then follow up every 3 months, monitor the risk factors, and look at, encourage the home blood pressure monitoring. The goal blood pressure not achieved after the first month of initiation, partial response, add another class of drug or increase the dose of the first agent. Do not hesitate to use 3 agents in case the target BP is not achieved. This is a very, very important statement. That means we need to hit hard, hit early. Don't go the stepwise management, which was age-old approach. But today you can use a single pill combination with 3 drugs, 3 agents, with a very big evidence what we have now, clinical trials, and the intensify the lifestyle measures. And of course, the side effects part you need to watch and substitute, replace, example, the pedal edema, amlodipine, very commonly seen. So the hypertension that you need to take care with a hit hard, hit early principle, and all guidelines say you start with a dual combination, not even one drug. So the key message is diagnosis of hypertension should be based on the office blood pressure and the cutoff 140/90. Home blood pressure ABPM is 135/85, and the 24-hour mean ABPM should be 130/80. So this 135/85 is very convenient, and you encourage. In fact, we did something like a patient, a BP apparatus is given and ask them to check their kith and kin at home, and we could diagnose about 30% of their kith and kin were hypertensives without symptoms. This is one random study which we did. So the drugs that block angiotensin pathway are the preferred agents for the treatment of hypertension in those with under the age of 60 and in the background of diabetes. Calcium channel blockers, diuretics, preferred agent in those over 60. And a majority of patients need more than one agent. Do not hesitate to initiate a combination therapy to start with, and a single pill and 3 drugs can be easily up titrated without hesitation when the targets are not missed and when the risk stratification is high. Thank you very much, sir, for patient hearing. And any questions, I'll be very happy to take it. Of course, Dr. Ashish and Dr. Taneja will answer all the questions.
Thank you, Dr. Srinivas. You answered my questions during your talk, and it was really absolutely wonderful, a clear message, and especially the lifestyle modification.
So one question.
Yeah, Dr. Please.
Taneja sir, आपके लिए.
Dr. Taneja has left. Dr. Ashish, you continue.
Yeah.
So do we have any clinical situation in diabetic hypertensives where other classes of antihypertensive drugs outweigh ACE inhibitors? I mean, they're preferred over the ACE inhibitors.
No, I didn't get the question, Prithvi. That means you want a drug which is better than ACE inhibitor.
Any clinical situation, yes, sir, the drugs that can outweigh the benefits of ACE inhibitors, any trials or anything?
No, see the ACE inhibitors, the trial-wise have got a pleiotropic benefit. See, we are not only targeting the hypertension control. We're
Yes.
talking about the pleiotropic benefits like the reduction in the microalbuminuria, the renal endpoints, the MACE event, the stroke reduction, all that with one class of drug. That is what we are trying to say. When you want to reduce the number, see, amlodipine is much, much stronger. It's like an ambassador car, which 10 people, 12 people can easily travel. That's something which is there, which you require. That is why if you see in the all combinations, amlodipine is like a horse. The remaining drugs are like a jockey. But you need a good horse to ride. The jockey is somebody who controls the speed, all the other techniques. So that is where the amlodipine CCBs is still my favorite drug in spite of all these inventions and so many other drugs. But still they do the necessity of bringing down. It's like metformin. Metformin
Yes, sir.
gram is what is required to reduce. Then all your pleiotropic benefits of all the other classes.
Yes, sir. Thank you.
Nice example.
Dr. Srinivas Murthy?
Sir,
Doctor?
Ketan sir.
Yes, sir. I thanks a lot to you for your nice lecture, excellent lecture. I want to know just the role of beta blockers in hypertension nowadays.
So nowadays the guidelines say it is only niche indications, usually your department, sir. Whenever people come to your department of cardiology, then that is the indication. Otherwise, only in youngsters we use. But of course, in Indian context, definitely it is a different scenario. We definitely use a beta blockers because our resting heart rate is much, much higher than the Westerners. So using a small component of a beta blocker, not your age-old atenolol, all that, but definitely now the bisoprolol, nebivolol have got a better role. And in young hypertensives, young diabetics, this is definitely a better drug in the Indian context.
Okay, thank you, sir.
I'd like to just comment on the beta blockers.
Sir.
There has been a renaissance of beta blockers. I remember way back in 82 to 85, our professor used to tell us that no patient of diabetes should be denied the benefit of a beta blocker. But unfortunately, because of atenolol, they went into disrepute. But recently, especially after the Indian heart study, as you said, the average heart rate of Indians is more than 85. That means we are basically an adrenergic nation. So beta blockers have become a very important role to play, not only because of that, but also now we have the modern beta blockers like metoprolol, carvedilol, bisoprolol, nebivolol, which are much better and have all the pleiotropic effects that we expect from them, especially in hypertension with heart failure, hypertension with diabetes, and all that. So that is regarding beta blockers. Another comment I would like to make about the controversy between the use of AC inhibitors and ARBs. If you look, both are equally good. There is no doubt about it. But because of the side effects of ACE inhibitors, if you look at the use of ARBs, they have jumped 10 times more than ACE inhibitors. But having said that, ACE inhibitors still remain the drug of first choice in patients with heart failure, ARBs in patients with CKD. So that differentiation, that's a thumb rule. And regarding calcium channel blockers, we have got the best evidence with amlodipine. It's a wonderful drug. Even it reduces microalbuminuria. But as per the RSSDI guidelines, if you look, they recommend cilindipine as the first drug of choice amongst the calcium channel blockers because it blocks both L and N, and it has got multiple effects on the both on the heart and kidney. And it also reduces microalbuminuria. It may not be as potent as amlodipine, but it does have pleiotropic effects. And after the
edema.
RSSDI guidelines, I've shifted to cilindipine, and I'm seeing very good results with even cilindipine.
Lesser pedal edema, sir. That is another one which is seen with
Pedal edema is also less.
Right. I think Dr. Garima has got raised hand.
Yes, sir. Good evening, sir.
Good evening, ma'am.
Sir, in a hypothyroid patient with pre-diabetic, if the patient is on telmisartan and amlodipine, so sir, how to change the amlodipine because it is causing pedal edema.
Okay, I think, see, it depends on, again, the risk stratification of the patient. Hypothyroid, well controlled, should have no business to have a pedal edema, the non-pitting edema, which we classically
So,
see.
sir, the patient has pedal edema. The patient has come for the first time. The patient is on telmisartan and amlodipine.
Okay.
He
And
has
thyroid. And thyroid is well controlled.
No, sir, the hypothyroid is also not controlled, so the patient has
Not controlled. Okay.
and pre-diabetic.
Got it. Then this is a good combination. So you need to explain them the risk benefit ratio. First, bring down the TSH, control it, then then you check them and talk to them. If it is a female, yes, it is something to worry because usually the footwear, the mark will be there and the females hate that to have that as a pedal edema, which is very conspicuously seen. Then I would prefer to change it, and the change can be ACE with a diuretic. That can be chosen if it is for cosmetic reasons, but the risk benefit ratio, what is the age of the patient, what are the other comorbidities, that is how you should consider, because that's something which most of us fail to recognize. One target is to bring down the BP. At the same time, the comorbidities and their extra benefits or pleiotropic benefits we should look at. We should always be very categoric, and whenever I start amlodipine, I tell them you'll have a mild edema, not to worry. That is like priming the patients for the adverse events. Like when you give GLP-1s, you prime them, the coming back or the discontinuation rates are very, very minimal when you do that. And that's what you should try to do, emphasize on the risk-benefit ratio of amlodipine.
So, sir, can we shift the patient to cilindipine, as sir said earlier?
With amlodipine, when you see pedal edema, what I've seen in practice, I'm sure Virmani sir will agree that cilindipine also doesn't make much difference as far as visually the pedal edema is concerned. These are all clinical trials, what we say, but visually it will not be much difference when cilindipine to amlodipine or amlodipine to cilindipine.
But if you give a combination of ARB plus amlodipine, the edema with amlodipine is much less as compared to amlodipine alone.
Yes, sir.
That is also a known fact.
Sir, with ARB or a diuretic, what are you talking about?
ARB.
Not diuretic. ARB with amlodipine.
Amlodipine. Now, there is one paper about the amlodipine causing less cough with ACE inhibitor. Less cough. ACE inhibitors, amlodipine is supposed to suppress the cough reflex.
Anecdotal evidence.
No. There is a paper, sir. It's a RCT. I can share it with you. I was also surprised. First time I read that.
Okay.
And this was in context of our triple drug. When we were preparing that paper, we could get this paper which talks about, that is the first time even I read. I was surprised. I read 2-3 times about that. How can it happen? It is a very complex mechanism suppressing your cough reflex center.
No idea.
Thank you, sir.
Thank you, ma'am. Thank you.
I have a question, Dr. LSM. So along with drug therapy, Dr. LSM also described LSM to be important. But one important thing is above 60 years of age, as per the guidelines, when the CCBs and the diuretics are preferred, in our context, in our part of the country where humidity and everything is high, in my experience, I can say that after many years of practice, that this electrolytemia is something with the diuretics, the non-loop diuretics ones. So how to go on with it, because we need to follow it up also with the electrolytes, particularly sodium, potassium. So what's your suggestion for using diuretics in these patients along with amlodipine or without amlodipine?
Yeah, when it's indicated, we need to use. And the only drug and the trial which is there in the elderly with an average age of 80 years is HYVET trial, HYVET,
VT, old one.
with indapamide, which has proven a mortality benefit. That's the only diuretic which has got a mortality benefit, RCT, and the average age in that trial is 80 years. So sodium hyponatremia is a very, very common problem, and the drowsiness is attributed to age. Many a times the
Yes.
attenders would see, "Ye kab se ho raha hai?" They say it has been there, doses of on and off. When we're talking only doses of, and sodium would be 125 or 129. These are the numbers which is seen. So that's something which you need to be having a high degree of suspicion. Doesn't happen. What I see is about 10 to 15% of these individuals will get into hyponatremia. I had my own 2-3 patients who went up to admission. I know to that extent I could not treat them on OPD basis, so I had to admit them. But you need to again look at the risk benefit ratio, and we should not hesitate to use, especially because of the static edemas what people have with the age. And this is one of the drugs. And indapamide, as I said, is the only diuretic which has got this mortality benefit.
But the more usage in India is of hydrochlorothiazide and nowadays
I know
a bit of
we are
chlorthalidone.
always peculiar. For example, if you see in the West, the ACE inhibitors are used more, ARBs are hardly used. But here we use ARBs more than ACE inhibitors. There are a lot of other factors other than science, I think. I think
No. After the on-target trial, probably telmisartan came above the ramipril, and then the combination. Earlier, we used to have combinations of ramipril and telmisartan together, like that, because those days it was being thought that it decreases the proteinuria more, and those days. Now it's poorly contraindicated. So probably after the on-target trial, the ramipril, the HOPE trial, and all those things have gone a bit down.
See, among all RAS blockers, telmisartan is a true 24-hour drug. No other drug has 24-hour action. We must accept that.
True.
And regarding there's a question in the chat box regarding which diuretic to use. As you very rightly said, indapamide is the most metabolic friendly. Is the drug of choice in elderly people. In others, there has been a fight between chlorthalidone and hydrochlorothiazide. But chlorthalidone again is a long-acting drug as compared to hydrochlorothiazide. And as far as the electrolyte disturbance is concerned, almost equal in both. I cannot say that it is less in chlorthalidone because recent trials have shown it's equal in both. So one has to be very cautious and pharmacovigilant regarding the electrolyte problem when you're using these drugs. Most of these people will end up with hyponatremia and you are in a problem. So be very pharmacovigilant when you're using diuretics. But at times you need to use them to control blood pressure. That is the problem.
Correct,
You
sir.
can't help it.
Especially in the elderly. Elderly, we need to be vigilant more.
But use it in elderly. If you use 6.25 milligram of chlorthalidone, I think it causes very less problems and it is very good. But I would prefer to use indapamide any day in elderly because it's very metabolic friendly.
Correct.
And another this thing, regarding the targets, even though the guidelines are mentioning less than 130 by 80, especially in patients with diabetes, there have been a lot of evidence regarding intensive lowering of blood pressure. And they are targeting to bring it down to 120 by 70, but definitely never below 120 by 70. Now, question is, the problem that occurs is orthostatic hypotension. But there is a reduction in the major adverse cardiovascular events. And so they have now, picked up the term from radiation, and they are saying use the LRA principle as low as reasonably achievable. That's the LRA principle. So today the target in diabetes, a blood pressure target in patients with diabetes is to use the LRA principle as low as reasonably achievable, but definitely not lower than 120 by 70. I'm sure LSM will agree with me.
True, sir. I think sprint trial gave us that evidence.
Yeah, recently we got number of trials now.
Yes.
And maybe the guidelines are going to change tomorrow.
Ashish sir, please take the question from the chat box.
Chat box. No, Dr.
Yeah.
Kashif Ali has raised hand.
That's already been taken.
Question like ARB, CCB, beta blocker, the patient diuretic, all the molecules are already there. When to choose an alpha blocker or a centrally acting one? The question on the chat box.
Yeah, in this setting, MRA would be the next choice, not the alpha blocker.
Correct.
MRA, resistant hypertension.
No, the question is when alpha blockers can be prescribed.
That is after if you are not able to control with MRS. Rule out secondary causes, rule out other comorbid conditions, and then you think of alpha blockers or centrally acting drugs. But they are very rarely used, and it is better to refer these patients to specialized hypertensive clinics. And today, there is also an emerging role of renal denervation therapy in selected cases of resistant hypertension. It is coming in a big way, but then question you have to see centers where they're doing a lot of them, because it is very important to know how many cases they are doing in a month or something like that, so that you know what results you're going to get. So it's very important. So judicious selection, not only of patient, but also of centers or doctors where you want to get it done. Both are important.
That in resistant hypertension, usually alpha blockers help because more decrease in the systolic blood pressure occurs with alpha blocker compared to the MRAs. What's your experience on that?
See, MRA basically is all guidelines mention MRA to be as the fourth drug in resistant hypertension, not alpha blockers. And unfortunately, there are a lot of these patients, significant number, who are having primary aldosteronism, which is often missed because we already put them on MRS and we do not investigate them. So basically, we are treating nothing but primary aldosteronism by using an MRA. That is why they are very important.
They're quite potent, Shankar. They're quite potent when you have MRA. Definitely, I think 80-90% of them would respond.
Yeah.
I think alpha blocker has got a very good indication in BPH.
Yeah, that was my point, sir.
In prostate.
If the patient is having benign prostatic hypertrophy,
that is a compelling indication for alpha blocker.
Orthostatic hypertension is something we need to.
Yeah. We have to tell them beforehand
Yes.
to take it only when going to bed, not beforehand and also.
if you give it,
Sir, one question I have. Suppose the patient is an elderly male. The patient is already on the selective alpha blocker for prostatomegaly or LUTS. Now the patient can alpha blocker like a Minipress XL or Prazosin can be prescribed if the patient is already on an alpha blocker, a selective alpha blocker for prostatism.
I think you should withdraw. You should withdraw that and put this for hypertension control. Don't put
No. So if the hypertension control is needed at that point of time, then we should withdraw the
selective alpha and then put on this.
Yeah. Don't
because we find prescriptions when both of them are being co-prescribed because separately.
They should not be combined together.
Yeah.
No.
Thank you.
Yeah.
Sir, one question about the polypill.
Yeah, Abhishek. Yes, sir.
What about the triple drugs, Combipill of metoprolol, amlodipine, and telmisartan? Is the another question in the chat box by Dr. Yugandhar Rao. Dr. LSM, please answer.
Yeah, you can use.
Yeah.
Triple combination, as I said, the guidelines recommend. See, they have to be genuine, they have to be synergism. They exhibit synergism, that is what you should choose. You need to be little, because our country, we have that, the tradition of combining illogical, unscientific combinations. So you should be aware about that, that's all. But SPCs are always the key, the backbone of your therapy, because no patient comes only with hypertension or only with diabetes. So there will be 6-7 classes. I showed one of the slides. Beyond 6 drugs, the compliance is only, 80% of them are non-compliant, non-adherent. 80%. So that's something which you should remember. So SPC is always encouraged, always, but the rational combinations you should use. That's the bottom line.
So Dr. Saxena, please, your final comments as the chair.
Is he there?
Dr. Ashish Saxena is here. Okay.
So we can.
Okay, thank you for an excellent session, Dr. LSM. Because the chairperson is not there, I take this privilege to thank all of you and hand over the session to our Secretary of Ccdsi, Dr. Abhishek, for
So,
further proceedings.
okay, sir. Thank you. I would like to request Professor K.K. Lohani, sir, for his comments. Thereafter, we will go for the concluding remark by Dr. A.K. Brahmani, sir.
I think both topics have been discussed very nicely by Dr. Daria and Dr. Srinivas Murthy, and there is hardly anything to comment about it. Again, as a chairman scientific committee, I would like to thank both the speakers and of course all the chairpersons and moderator. I hope with your cooperation, we will be continuing with E-Cme every alternate month. So let us hope in January we will meet again. And thank you. And so far, the scientific part of both speakers are concerned. The first talk was precise and very informative, and second talk was very comprehensive, which included everything. But then it was very interesting. So thank you, Dr. Srinivas Murthy, and thank you, Dr. Daria.
Dr. Virmani, sir, for your comments regarding these two topics and the plan of the CME
I think
and anything, what should we improve
Yeah, I
as a
think
dean?
I've already made too many comments for both the speakers, but then both were excellent. There is no doubt they did full justice to their topics, and both are. I know personally, both of them are excellent. Not only they have got superb academic knowledge, and Dr. L.S. Murthy is one of the most genuine researchers in India. There is no doubt about it. And it was really a pleasure listening to them today. And I think there is nothing more to comment. They have done full justice to the job. Thank you, and over to you, Abhishek.
Thanks, sir. Thanks a lot.
Abhishek, just one word, sorry.
Sure.
Just to tell, because it was a hypertension topic, now there is a phase 2 trial, which is a guanylate cyclase inhibitor at the level of mitochondria, phase 2 trial, which is called Neurandicitron. NEEO, very difficult tongue twister name. We just completed a phase 2 trial from Bayer. Another trial, phase 3A, which is baxdrostat, which is aldosterone synthase inhibitor. And the beauty is there are two trials. One is baxdrostat alone. Another one combined with a DAPA, in hypertension. And we are just starting another trial with orforglipron, which is a oral GLP-1 tablet in hypertension. Orforglipron, I have a paper in Lancet for diabetes and GLP-1, the oral GLP tablet from Lilly. The what you see is the other one is from Novo. But this orforglipron, now they are starting a trial in hypertension patients. So this is how the progress is going on. I thought I'll just tell you.
Dr. LSM, I want to ask one thing. I know if the program is over, but still, I got nowadays the pharma companies are coming with combination of dapagliflozin and bisoprolol.
Yes,
Any
I
comment?
was
Any
about to
comment?
ask.
Yeah, Dr. Abhishek. This is a good opportunity to learn from this
Totally
August.
irrational. Totally irrational.
Yes. No evidence.
One word, totally irrational.
I don't know how they get the approval trial, sir. Very
Oh, that's
surprised
very easy.
it happens.
That's very easy.
What is the indication they are thinking? Means what is the thought of process that is
Diabetes,
important?
hypertension.
Sir, issue is that DAPA or any SGLT2 inhibitor has to be withdrawn in about 20-25% of the cases because of the side effects we already know. And bisoprolol is so good molecule that once your patient is settled, you don't want to withdraw it.
Yeah.
So it is very illogical also, sir. I don't think it is it will be supported in long term. So it is time to thank all of you. In fact, I'm very thankful to our founder president, sir, dean, sir, all the faculty members, excellent speakers, excellent panelists, our past president, especially Dr. Taneja, sir, who got some time to bless us. I am very thankful to moderators, Dr. Smita Gupta, ma'am, and Dr. Shankha Sen, sir. Shankha Sen, sir, has to go somewhere, but because of the schedule, he has stayed here. Thank you, sir. Thanks a lot. I am thankful to all the delegates, the students, And I have also seen the few delegates in the CME who are not members of our society, but they were invited by all of us, I think, from the various parts of our secretaries, and they have attended it. Knowledge sharing is free to all. It is not necessary that you are a member of CCDSI, you can attend. Anybody can attend. And some of them have demanded for the YouTube link. Just after the CME, within few minutes, I will going to provide the YouTube link of entire talk. So it is very good day for us, a better day than the earlier, that the sister organizations, the members of the sister organizations are also joining. And this reflects the thought process of our scientific chairman, sir, our dean, sir, our president, sir, and all the seniors. So thank you. Thanks a lot to all of you. And thanks for bearing with us. I thank Three Dots Pharma also. They have provided more than 30 minutes extra to us. Thank you, Drivasi and all. Thanks a lot.
Thank you. Good night. Take care.
Good night. Good night.
Thank you. Thank you.
Good night.
Good night, everyone.
Good night. Good night, everybody.
Thank you.